All right, let's jump right into this explainer. We're breaking down the GINA 2026 asthma guidelines. And look, whether you're a PG medical student trying to lock down your clinical acumen for the wards or you're already an active practitioner, mastering these updates is absolutely critical for modern respiratory care. We're going to distill the primary diagnostic criteria and the core treatment tracks for adults, so you can literally apply this on your very next rotation or clinic day. So let's kick things off with a pretty massive paradigm shift, one that honestly challenges how a lot of us were trained. We have to ask, is your asthma prescription actually driving mortality? I know, it's a provocative question, but we really have to face it. For decades, we were all taught to rely on SABA-only prescriptions, short-acting beta agonists like albuterol, for quick relief. But the latest data, it forces us to ask if this reflexive prescribing habit is actively harming our patients. Here's the bottom line. Using short-acting beta agonists as a standalone treatment is now officially recognized as a driver of mortality. That means SABA monotherapy is completely out. It is no longer supported at any step of asthma management. GINA 2026 makes this incredibly clear. Relying solely on a SABA leaves your patients completely vulnerable to silent inflammation, severe exacerbations, and even death. And yes, that includes the patients who sit in your exam room and swear they feel perfectly fine between their acute flare-ups. So here's our clinical roadmap today. We'll hit the paradigm shift, diagnosing adult asthma, track 1, which is the preferred path, managing acute exacerbations, and wrap up with looking beyond the inhaler. Part 1, the GINA 2026 paradigm shift, ICS for everyone. Listen, under this new framework, every single patient gets an inhaled corticosteroid. No exceptions. Even those patients presenting with super mild, totally intermittent symptoms, they must receive ICS-containing therapy. We can't just hand them an albuterol inhaler and wave goodbye anymore. For those of us in primary care or on clinical rotations, this is literally your most actionable takeaway. You need to actively comb through your roster, find anyone still on a rescue-only regimen, and immediately transition them to an ICS to protect their airways. Moving on to Part 2, diagnosing adult asthma and getting those criteria right. Now, before we even think about handing out that ICS, we've got to lock in the diagnosis. The GINA diagnostic workflow emphasizes one vital thing. You absolutely have to confirm variable expiratory airflow via spirometry or PEF before you start the ICS. As PG Med students, internalizing this workflow is huge. You have to get the objective data up front. Why? Because once you start an inhaled corticosteroid, it blunts the variability of both their symptoms and their lung function. If you wait, confirming that diagnosis later on becomes incredibly difficult. And speaking of the criteria, GINA 2026 actually resolves a massive diagnostic debate. They firmly retained the older 2005 ERS/ATS criteria for bronchodilator responsiveness. See, there was a proposed update in 2022 to use a greater than 10% of predicted metric. But it turns out that actually results in dangerous underdiagnosis, especially in younger males who have high respiratory burdens. The large data sets prove the 2022 proposal just misses patients who genuinely need care. So, when you're on the wards, stick to the tried-and-true 2005 numbers. We are looking for a 12% and 200 milliliter increase from baseline. All right, Part 3, Track 1, the preferred path. Before we get into the actual steps, let's define what we mean by air therapy. That's anti-inflammatory reliever therapy. This is the use of a low-dose ICS for Motorol inhaler used both as their maintenance daily med and as needed for symptom relief. You'll often hear this called MART or SMART. Air therapy represents that massive clinical pivot away from SABA we talked about earlier. By using formoterol, which is a fast-acting but long-lasting bronchodilator, combined with an ICS, you are treating the underlying airway inflammation at the exact same time you're relieving the acute symptoms. It's a 2-for-1. So the track 1 pathway is beautifully simple. It uses a single budesonide formoterol inhaler as the absolute cleanest, evidence-based regimen across the board. In steps 1 and 2, it's used just as an as-needed air reliever. Then, as you move all the way up to step 4, the patient takes maintenance doses morning and evening, plus extra inhalations as needed for relief. The genius here is that it's just one inhaler device for both control and rescue. Think about how much that simplifies patient education and boosts adherence. And if you're wondering why Track 1 is the heavy favorite now, the data is honestly staggering. Clinical trials show that using this as-needed ICS formoterol strategy yields a massive 60 to 65% reduction in severe exacerbations compared to SABA-only relief. 60 to 65%.
It also slashes systemic corticosteroid exposure and cuts down on urgent care visits. When you prescribe Track 1, you aren't just treating symptoms, you are actively keeping your patients out of the ED.
Now sure, GINA does outline a Track 2 alternative. Track 2 uses an as-needed ICS-SABA combination, or just a regular SABA reliever if the combo isn't around, alongside a daily maintenance ICS. And while Track 2 exists for specific clinical scenarios where maybe you need separate relievers, Track 1 is still highly preferred. Why? Because Track 2 requires 2 different inhalers for steps 2 through 5. That immediately spikes the patient's cognitive load, increases the risk of poor adherence, and frankly causes confusion during a panic-inducing asthma attack.
Part 4. Managing acute exacerbations right at the point of care.
So, when you're in the ED or urgent care, there are some really critical changes here. We used to just blast patients with liberal oxygen and heavily rely on bronchodilators, right? Well, scratch that. The crucial point now is titrating that oxygen, aiming strictly for 92 to 96%. You also need to watch like a hawk for refractory tachypnea. If a patient is still breathing rapidly after repeated SABA nebulizations, do not just blindly give more SABA. That is a major red flag for SABA-induced lactic acidosis. Plus, the whole modern protocol is designed to be anti-inflammatory right from the jump.
Another huge piece of the acute puzzle is instantly recognizing who is actually at risk of dying. We have to know the red flags for fatal or near-fatal asthma. In fact, every single primary care visit needs a brief screen for these. Did they have an ED visit last year? Have they ever been intubated? Notice that SABA overuse is now defined as going through more than 1 canister a month. If you see that, or if they have a food allergy combined with asthma, their risk profile is sky high. Even one red flag should trigger a total review of their treatment plan.
Finally, Part 5, Beyond the Inhaler, looking at holistic asthma care. Because it's never just about writing the script, right? Before you ever step up a patient's therapy, you absolutely have to watch them actually use their device. Poor inhaler technique is literally the most common reason for treatment failure. And while you're doing that, you've got to be a detective, address environmental triggers like mold, and optimize comorbidities. Things like nasal polyps, sleep apnea, or obesity can mimic or severely worsen asthma symptoms. And for those really tough, uncontrolled cases, checking type 2 biomarkers like FeNO and blood eosinophils is standard practice now to get them dialed in for biologic therapies. So, I'm going to leave you with this question. Will you review your asthma roster this week? It's easy enough to passively listen to guidelines, but the real impact happens when we change our habits. Take a look at your patient panels in the coming days, check their adherence, and get them transitioned over to ICS-containing therapies. Taking that proactive step is exactly what prevents exacerbations and saves lives. Thanks for tuning into this explainer. Let's keep pushing the evidence and elevating our practice together.